we do not give advice, and so we want everyone to know that the information you get here is not to be in place of information that you would get from your own treating physician. We traditionally don't endorse or recommend views expressed by our presenters, and although in tonight's case we probably make an exception. If he could, Dr. Myers could come up here and read the phone book, and he'd have my undivided attention. And we just have to go through that little song and dance because of the litigiousness of our society today. We do want everyone to make their own informed decision, and we would like to help steer you in that direction if you're deciding what treatment, but we don't endorse any particular point of view. We do record our presentations so that we ask everyone to hold questions and answers to the end. We'll have a question and answer period. If you just make a line over here, we'll use this microphone so everyone can hear the question and then Dr. Myers' answer. After the presentation, we'll also ask that we clear the chapel. If you have pressing questions you'd like a little bit of personal time, I think Dr. Myers will kindly consent to that, but let's not ask too detailed of questions that would reflect personal treatment kinds of diagnoses or recommendations, as no one, even Dr. Myers, would not be, I'm sure, willing to give any kind of off-the-cuff, formal kind of diagnosis or treating recommendation. So if you have questions, I'm sure he will answer them, but let's let him clear this area here. We'll get off this podium where the stairs can be troublesome to anyone trying to walk up and down. So we'll after the presentation, we'll ask that we clear this area, and he'll make himself available in the back of the in the foyer for some ongoing questions and answers. Let me bring up our fearless leader, Mr. Murray Corwin, who many years ago had the inspiration to start this group. And I know when he comes up here and turns around and sees how many people came tonight, very impressive from the early days of maybe 1 or 2 or 3. And the fruits of your labor, Murray, are here in front of you. Thank you all for supporting us.
Thank you, Larry. 2 small things that I didn't tell Larry we need to do home. If you have your cell phone on, we would appreciate much if you turn it off so we don't get interrupted during the talk. And there's a process going on in which we are publicizing our presence and letting people know that we exist. We learn that there are people who need us and don't know that we exist. And so we have this campaign to put flyers and brochures out, and we have a volunteer group doing that. Those of you who have volunteered, and thank you, and have not picked up their November grouping, you'll find it alphabetically placed on a table just outside the sanctuary. Thank you. Now it is my great pleasure to introduce you to tonight's speaker. I think of him as not only a friend, but he's probably one of the 2 medical oncologists in this world whose opinions I find are so relevant and highly respect. Dr. Charles Myers, nicknamed Snuffy by his own choice, nationally renowned, internationally recognized as a outstanding medical oncologist whose practice is focused solely on prostate cancer. I'm not sure I can truly give you an appreciation for what that means, but many oncologists that you may know have to treat many, many different kinds of cancers. Dr. Myers is focused on prostate, and that keeps him, I'm sure, busy and his entire attention. So you get the best of the bunch tonight. He himself is a prostate cancer survivor, and so as he speaks to you, he comes from a place where he can empathize with your current needs. He's a researcher, an author. There are books he's written, papers, constantly in demand at the national conferences. He's founded the Foundation for Cancer Research and Education. He spent some part of his career at the National Institute of Health for many years. He's also director of the American Institute for Diseases of the Prostate. He's really a walking fount of knowledge. And he's come tonight through a harrowing trip he was telling me about, he and his wife, from Virginia, Charlottesville, Virginia, to speak to us tonight. And it's, in my view, an extraordinary special occasion. So please welcome Dr. Myers.
Thanks. Well, it's good to be here. This group certainly, and I certainly go back a long way. He mentioned that I had prostate cancer. In February of '99, I was diagnosed with a prostate cancer that had spread to the lymph nodes of my pelvis and one node in the back of my abdomen. So this February will be my 10th year anniversary. So it'll be a special time. So because of that history, I focus with a particular intensity on how to get a complete remission and how to stay there with the least amount of damage. And so that certainly colors what I'm going to say. And of course, you always need to know the biases of the experts who are speaking. And more than anything else, this personal experience has biased my view of the disease. Now, by way of leading into what I'm going to say, you need to know that in the year 2007, there were more than 5,600 papers published on prostate cancer, the medical and scientific aspects of it. Not only were the number of papers large, but their importance is fundamental. So that in my own thinking of this disease, I think of before and after 2007. So those of you that have heard me speak before, you'll hear some very different conclusions than before, based on some stunning findings that came out in 2007 that have been since validated by other studies. So I guess by way of starting, let's talk about how we now understand what cancer is and how that governs how we should approach it. And I think I'm going to start with an organ that isn't the prostate, but the liver. If I were to go in and cut out 2/3 of your liver and throw it in the trash can, I'd come back 8 weeks later and open you up, and I'd find a normal liver that looked the same as the one that was there before. Same size, same shape. So how is that possible? Well, right after I'd cut out 2/3 of your liver and threw it in the trash can, there are stem cells in the liver that are quiet, just waiting to be needed. And the removal of a large portion of normal liver would turn on those hepatic stem cells. They would then generate a population of cells that are rapidly growing that would go up and fill the missing space. And through some magic of biology, they would recognize when the liver had reached the right size, and then they would shut off. Now, more or less, this process is taking place in most of the tissues of your body. Even the brain has stem cells. Turns out we now know that throughout adult life, new brain cells are forming and going up to the cortex. And if that stops, you'll get progressive dementia, memory impairment, and so on. So this is why, of course, stem cells are so interesting in medicine, because there are many diseases that we could repair if we could put a normal stem cell in there to regenerate the damaged tissue. For example, you can take a heart and damage it and then repair much of the damage with the appropriate stem cell population. Parkinson's could become a thing of the past. So that's therapeutic stem cell work, and of course that's what's been such a political hot potato for much of the last few years. Now, behind the scenes, of course, people have been asking the question, well, if stem cells have the capacity to do this, what role do they play in cancer? Well, I guess the answer today is we think that cancer is a stem cell disease. The cancer stem cell is less able to turn off and be silent, more likely to be constantly active. Stem cells across all cancer types seem to generate a rapidly growing pool that's capable of expanding and then giving rise to cells, cancer cells, that don't grow but fill most of the mass. So for most cancers of adult life, if you're dealing with a kilogram of cancer, 95% of that cancer is not growing, it's just filling space. About 5% may be this rapidly turning over pool, and 0.1% would be the stem cells. Now, what I'm saying is true for breast cancer, leukemias, and prostate cancer specifically. So for prostate cancer now, techniques have been developed. For prostate tissue, normal and cancerous, we can go in and isolate the stem cells. So recently there was a paper where they took normal prostate stem cells. We have mice that have no immune system. So you can take human tissues and graft them into the mouse, and they'll do just fine. So they isolated stem cells from a normal prostate and put it in the flank of these mice. And lo and behold, they had a normal human prostate grow up from these stem cells. So in 2007, there was one of these key papers. They took prostate cancer out of patients, broke the cancer up into individual cells, and they had a fairly large bucket full of cells that were making PSA and that had the testosterone receptor and therefore were hormone sensitive. And we know ahead of time these cells don't do a lot of growing, even though they're the bulk of the cancer. You move this into one of these mice with no immune system, and the cells double once or twice and form a little nodule, maybe the size of the head of a pin, maybe no bigger. If you take the 5% of the cells that are PSA negative, don't have testosterone receptor, but are doing all the growing, and put them in the mouse, these cells will rapidly grow up to a mass and then stop. No metastasis, no continued evolution of it. So while they can grow, they can't grow indefinitely. They reach a capacity and they stop. Finally, the stem cells, the cancer stem cells, which are typically 0.1% or less of the population, you put them into this mouse, and for a while, nothing happens. Those stem cells are staying latent, dormant, just like the normal stem cells in the liver. Then gradually, at various periods of time, depending on a mouse, which mouse, the stem cells would take off and make a little nodule that got bigger and bigger, and then metastasis formed. And you look at the tumor, and it duplicated the Gleason grade of the patient that donated the cancer. So all of the information that governs the final behavior of a cancer is in these stem cells, which are no more than 0.1% of the original cells. Now, we come in and put you on hormonal therapy, and there's a huge drop in the size of your lesions. Maybe your bone scan improves. maybe your lymph nodes that are large normalize. And we take you off hormonal therapy, and after a while, the cancer comes back. So in stem cell terms, what's happening? Well, during hormonal therapy, we kill the cells that make PSA because they also depend on testosterone. These cells that are PSA negative, that are capable of rapid growth, for some reason become quiescent, but they're not killed. And the stem cells aren't touched at all. So you're basically, with hormonal therapy, just skimming the top off. That's taking away testosterone. You're just skimming the top off. Another way of thinking of this is that the actual manufacturing plant for the cancer includes a rapidly turning over machine, the PSA negative cells, that are spitting out the end product, which are non-growing PSA positive cells. Now, with each cycle of hormonal therapy, these PSA negative population grows. So gradually, as time passes, a pound of cancer makes less PSA. And eventually, when we get hormone resistance, the actual amount of PSA is very low. Why? Because these PSA negative cells that are hormone resistant and capable of rapid growth are what are progressing. Now, these PSA negative cells that grow rapidly themselves have maturation process from primitive to more adult. Now, it turns out that when they're in their most primitive and most dangerous form, they make a protein that makes them immune to Taxotere. The same protein was first described in breast cancer as a breast cancer resistance protein. So again, it emphasizes the theme. When you get down to this level, prostate cancer and other cancers are all the same. It's fascinating. So when I put the patient, when you take someone who's failed hormonal therapy and you put them on Taxotere, the cells that are sensitive are only the ones at the tail end of this PSA negative population. The nastier, more aggressive cells are still there and aren't sensitive to Taxotere. This is why systemic treatment like hormonal therapy and radiation therapy are usually not curative. But wait a minute, all of us know people who've gone through hormonal therapy and are now off hormonal therapy on some kind of nonspecific support mechanism, and the PSA hasn't come back. What's going on there? There are also other puzzles that weren't so easy to explain. In people who've had radical prostatectomies, patients will continue to relapse out as far as 25 years after the original surgery. In fact, one study claimed that half of the relapses after surgery occurred 10 years or more after the surgery. We see the same thing for breast cancer. Women who've had a mastectomy for breast cancer have been reported to recur 30 years later, with no evidence of the cancer in between. Melanoma, skin cancer, the same way. If you have a melanoma that's treated successfully with surgery, decades later that same melanoma can come back. Well, this gets to the second major paper in 2007, published in Nature Reviews. Now, Nature Reviews is a very special journal, published by the people who published Nature, which was one of the most prestigious scientific journals. And when a field of investigation reaches a certain level of maturity that everyone doing science needs to know about it, the editors ask them to write a review. And so there was a review in Nature Reviews on the whole idea of tumor latency. The whole concept that the cancer can go invisible and silent and decades can pass and then it can activate. And this review was an extremely detailed, comprehensive review of everything we've known about this process. To give you an idea, it took me 2 weeks to digest the paper. sitting down, chasing down the citations at the end of the paper for this point or that point. And it was worth the effort. It was that important a paper. Boiled down to the basics, they reported 3 processes that are able to keep cancers dormant at the stem cell stage, or after the stem cells given rise to a small population of rapidly proliferating cells. And these are actually fairly easy to explain to you in lay terms. The first mechanism they described is a failure of new blood vessel formation. For the stem cell to give rise to a mass, it's suddenly got to go from being a quiet cell to attracting blood flow. So we now know that cancer cells produce hormones that cause any nearby blood vessel to bud off and to deliver a new blood vessel to the cancer. One of the best known of these is VEGF. Very important hormone for those of us involved in prostate cancer, because it is the major hormone that prostate cancer cells use to attract a blood flow. So the first mechanism is anything you can do to cause a failure of the process of new blood vessel formation. So for prostate cancer, we have 3 agents that are available for oral use and 1 for intravenous use that block new blood vessel formation. And I like to think of them as light, medium, and heavy duty. The light duty agent is Avodart and Proscar. The activity of Avodart and Proscar against prostate cancer occur because they prevent new blood vessel formation. Why is that? Turns out dihydrotestosterone is different than testosterone, and the fact that dihydrotestosterone causes new blood vessel formation from the cancer and testosterone doesn't. So these 2 hormones, although they're both androgens, are very, very different in how they function at the level of the cancer. Now, I call it light duty because it's easy for the cancer cells that are more aggressive to overcome this block and become independent of dihydrotestosterone. That's also light duty because the side effects of Proscar and Avodart are minor. They're 2 drugs that you can't commit suicide with. They're 2 drugs that are actually prohibited in the Olympics because they enhance athletic performance. Now, in my practice, I don't often get to prescribe athletic enhancing drugs, so this is a real turn-on to use these drugs. A little bit more heavier duty is Celebrex. When Celebrex, the drug used for pain, arthritis, is given at doses of 200 or 400 milligrams twice a day, it is able to block new blood vessel formation in many cancers. And there are 3 clinical trials showing that Celebrex has an impact on prostate cancer. Now, the good news is this also takes away your aches and pains. So that sounds pretty good, but this is a drug with a dark side, which means that it isn't for everyone. First, it's based on the same chemical structure as sulfur antibiotics. So if you're allergic to sulfa drugs, you could be allergic to Celebrex. And some sulfa allergies are potentially lethal. So this isn't a minor issue. And second, Celebrex is a COX-2 inhibitor, and COX-2 inhibitors can increase blood pressure and accelerate atherosclerosis or heart disease. Bextra and Vioxx had to be removed from the market because they did this so severely. Celebrex's action in this regard is much milder, and it remains on the market. But fortunately, there have been detailed reviews, and it appears that Celebrex is okay for your heart if your blood pressure and cholesterol are within the perfect range. That would mean a systolic blood pressure less than 120, and an LDL cholesterol of under 100. Now, there are other issues that can cause heart disease that have been less well addressed. So if you have heart disease on some other basis than these two, then we may not know whether Celebrex is safe enough for you or not. Nevertheless, there are many, many people where Celebrex is and Avodart make a very useful combination to block blood vessel formation in prostate cancer or to slow its progression. The next agent is a high-test one, and that is Sutent. The word tent, T-E-N-T, with an S-U in front of it. And it's a once-a-day pill that shuts down the EGF. So it specifically attacks the hormone that almost all cancers use to establish new blood flow. It's approved for kidney cancer, but there's a growing literature of its use against prostate cancer. It is extremely powerful. Now, that power is both a good news and bad news situation because VEGF is used by normal tissues. Well, if you're out of shape and now start going to the gym and trying to get into shape, your cardiac output will gradually improve and the ability of your muscles to do work will improve. Why? Because your muscles produce VEGF, and this attracts blood flow to your muscles, your skeletal muscles in your heart. If you're on Sutent, the training effect cannot take place. If you start having a cholesterol plaque blocking your coronary artery, if that proceeds slow enough, your body can build collaterals around that block. On Sutent, that won't happen. So you could have a serious heart attack or stroke if your cardiac health is less than perfect. Typically, Sutent is given for 2 or 3 weeks, and then the patient is given 1 or 2 weeks off because of the penalty you pay for a continuous blockade of this. So it is high test. However, what it can do is transforming. I have some patients who have Gleason 10s and PSAs that double every 14 days. And a handful of these men, the cancer has been blocked from returning by Sutent. That's how powerful it is. There's an intravenous agent that does the same thing that Sutent does, and that's called Avastin. But it's increasingly unpopular because of its expense, the need for intravenous administration, and the fact that it can be associated with fatal reactions. Nevertheless, there are clinical trials to show it markedly improving the benefit that patients get from Taxotere. So that's the first mechanism this paper talked about. The second mechanism involved is to trigger an ongoing immune attack on the cancer. Now, of course, ideally, what we would like is a vaccine that would do this for every cancer and have a vaccine that would work by targeting an antigen associated with the stem cell population. Unfortunately, all the vaccines being developed for prostate cancer are targeting proteins that are produced by the PSA-positive testosterone-sensitive population. PSA, PAP, so GVAX and Provenge all are targeting the wrong target. We do have one agent that will work to trigger an ongoing immune attack on prostate cancer that is FDA approved for other diseases, and that's Leukine, Leukine. Now, if you develop a pneumonia, your white count goes up. Those white cells come out of the bone marrow. So one of the interesting puzzles of biology is how the hell did the bone marrow know there was trouble out there in the lung? Well, there are a set of hormones that inform the bone marrow, in lay terms, to send all the troops. There's trouble out here. We don't know what it is, so send everybody. And that's basically what Leukine does. They've cloned the gene for that, moved it to yeast. They grow the yeast in large vats, harvest the protein and put it in a vial, just like human insulin. And you inject that, self-injection every day, and it triggers a non-specific immune response. And prostate cancer gets caught in the crossfire. Now, prostate cancer isn't the only cancer where leukine looks like it might be beneficial. Melanoma skin cancer, non-Hodgkin's lymphoma, breast cancer, to name a few. This agent also has profound effects on the immune system in other ways. Half of the people with ulcerative colitis will go into remission. Ulcerative colitis has a similar immunologic basis to psoriasis and ankylosing spondylitis. And I would note that almost every patient in my clinic with psoriasis would go into remission while they're on leukine. It's also been reported this causes not only the white cells to fight off infection to come out, but stem cells to repair injury. And so it's been reported to reverse the damage caused by radiation therapy. And indeed, in our clinic, and someone comes to me bleeding from the rectum because of radiation, this is a good bet to stop that. Finally, there's a paper that looked at people with angina and coronary artery blockade, placebo versus leukine, and the patients on leukine, the angina got better, and when they relooked at the coronary arteries, collaterals had formed around the block. So in essence, it had repaired the damage that had been caused during the development of ischemic heart disease. So all these things make leukine a fascinating agent, and this has led to interest in this by a growing range of investigators. Leukine can be given by itself, in which case it will slow progression of this disease. Eric Small from University of California, San Francisco, in 2007, published 5-year follow-up of people with advanced disease whose cancer had been controlled for 5 years on leukine. Of course, it's also interesting to decide, well, what would I combine leukine with? And Eric Small again published a paper in 2007 showing that we combine leukine with ketoconazole. In hormone-refractory prostate cancer, there's a 75% response rate. That's better than Taxotere, chemotherapy. That's a higher response rate than Taxotere from second-line hormonal therapy and an immune stimulant, for God's sake. So it's impossible not to become excited about leukine, even though it's not specific. There are many patients where whose disease can be controlled with leukine. And with Eric's paper published in 2003, there are a portion of the patients in my clinic who are on this cycle of on and off treatment who now have remained off their cancer in control. It's not a solution for everybody, but a solution for some patients. The most dramatic case I have is a patient who I had seen first in December of 2002, a month before Eric Small's first paper, and he had a Gleason 10. His first PSA was 140. 4 days later, it was 170. So his PSA was doubling every 14 days. He failed hormonal therapy in 7 months. So those of you who've seen much prostate cancer, you recognize immediately how serious this is. With Taxotere chemotherapy done every which way I could think of, by April of 2003, his PSA was undetectable, and his bone scan and CT scan showed no evidence of disease. So he was in a complete remission. For the next 3 years, every 4 months, he had 30 days of leukine. So in 2006, he stopped the leukine. His hormonal therapy stopped in April of 2004, and so he was on leukine and Avodart, and since 2006, he's been on Avodart alone, and his cancer's never come back. Now, I've been around prostate cancer a long time, and I've never seen Taxotere by itself do that. So I have to believe that leukine played a critical role in this man's long-term disease control. Now, this is, of course, an area that's undergoing rapid growth of research. And so one of my colleagues got the bright idea in terms of looking at what to combine leukine with, to ask, what do we give to AIDS patients to improve their immune system? Well, thalidomide. Thalidomide is widely used in AIDS patients to improve their immune response, and indeed it does do that. So about 3 years ago at our spring cancer meetings, they reported 7 patients with advanced disease treated with low dose of thalidomide and leukine for 1 month. 6 out of the 7 had what they termed massive PSA decline. And they noted in the abstract that the patients didn't need to be retreated for 6 months or more after that. The responses were so dramatic. Well, of course, as things go in this field, 6 out of 7 was too good to be true, wasn't it? So as experience has grown, it's settled down around 30 to 40% of the patients have a massive tumor response occurring within 14 to 28 days. Now, thalidomide is not a nice drug. It was developed as a sleeping pill. And so when you're on thalidomide, you're going to be drowsy. Let me put it this way. No one has ever complained of insomnia while on thalidomide. It can cause blood clots. With chronic use, it causes peripheral nerve damage, so people get numbness and tingling in their feet and may fall and lose their balance. So as I say, there's room for improvement. There is a new and improved version of thalidomide called Revlimid, R-E-V-L-I-M-I-D, that's even more effective when combined with leukine. And here, the responses are very rapid. Really, within 5 days, you can see a dramatic impact. And 14 days is often all that's required to get a major response. And I'll just give you some cases histories so you can get the feel for this. I had a patient from Minneapolis, a young man in his 40s who was a professional dancer, modern dance. Had his own dance company. And he had not responded to thalidomide alone. And he had not responded to leukine alone. And he was at a point where his PSA was 3,400, and he was entering hospice and on intravenous morphine. The agents were started on a Friday. By Monday, his PSA had dropped 1,000 points. And by the end of the month, he was out of hospice and back working with his dance company. Now, it lasted for another 6 months, and then his cancer got resistant to that. But you get the flavor of this. For Revlimid, I have a patient from South Africa who had failed all known chemotherapy agents. The PSA was just over 1,000. His blood counts were such that he couldn't receive any more chemotherapy. And in 14 days, the PSA went from just over 1,000 to 280. And the disease was again controlled for about 6 months. Another patient was originally a patient of Dr. Leibowitz who had failed that approach and chemotherapy and had an enlarging mass in his pelvis that was threatening to block off both bladder and kidneys. In fact, they were talking about needing to divert his bowel and kidney drainage to the skin. And he was wheelchair ridden because of the damage the advanced disease was causing. His platelet count was very low, and Revlimid suppresses the platelet count. So the initial treatment was only for 5 days. PSA went from 1,250 to 480 in 5 days. We then had to let his platelet count recover and then we went back again. This started in February of '07, and he steadily got better, and his PSA steadily dropped until it was in between 100 and 200, and he was able to play golf. But after 18 months, the treatment failed. And I just recently developing widely growing metastatic bone disease. But still, after everything else had failed, this gave him 18 months of disease control. So it gives you an idea of the power these immunotherapy agents can have if you're lucky enough to have a cancer that's sensitive to hormonal therapy approaches. An extensive pre-existing radiation therapy and chemotherapy do not appear to damage the immune system enough to compromise the ability of this to work. The third group of agents are a little bit harder to explain in lay terms, and I've struggled for how to relate this. I think the best way to understand it is these are agents that effectively reduce the Gleason grade. You know, the higher your Gleason grade, the more rapidly your cancer grows, the more likely it is to spread, the more likely it is to get resistant to treatments. And these agents just repeal that clock. They reduce the ability of the cancer to grow, to spread, to become resistant to treatment. In fact, it may reverse hormone resistance. These agents may reverse hormone resistance. This is the least well-developed of the agents that we've got. I first started working in this field in the early 1990s with a drug called phenylacetate and then phenylbutyrate. And then we looked at the retinoids. And there are now other drugs like Depakote and Vorinostat that have this kind of activity in some patients. That's the problem. Each of the agents that we have only work in a portion of the patients, and they all have significant side effects. Probably the most exciting one and the newest is the active ingredient in red wine, resveratrol. Now, the problem is that it's really hard to get clean, pure resveratrol. The second problem is that the human liver avidly destroys resveratrol, so we had to solve those technical problems. But there is a group of patients with prostate cancer where resveratrol will stop their disease or maintain tumor dormancy if you got the patient in remission. And in general, resveratrol is free of most side effects. Some people will get diarrhea if the dose gets too high. The biggest problem with resveratrol is that it interacts with other drugs. And the most frightening interaction it has is with Coumadin, the blood thinner. It markedly increases the blood thinning of Coumadin. To give you an example, I had one patient on 20 milligrams of Coumadin a day. On resveratrol, he needed 2 milligrams. So it's very easy if someone grabs resveratrol over the counter and starts taking it while they're on Coumadin for them to bleed to death. This is a potentially lethal interaction. And there are lesser but also significant interactions with the cholesterol-lowering drugs and with a group of antibiotics that are widely used to treat pulmonary infections in men in this age group. So I would regard resveratrol as very promising, but also really hairy to use right now because the issues aren't fully defined. Now, I've had, of course, talked about individual agents. I think the most promising strategy is to pick one of each class. Ideally, you would know what genes the patient's cancer is dependent upon and pick one from each of this list for the patient's tumor. And that's a growing likelihood. Right now, I've had great success with leukine and Celebrex or leukine and Sutent, and a limited experience adding resveratrol to that mix. The whole goal here, though, is to take patients whose cancer has been knocked down to a low level by other treatments and now use these agents to keep the cancer from regrowing, hopefully to put the tumor stem cell into latency. So with that background, how would I approach someone who newly comes to my office with widespread metastatic disease? And I've actually written a book about this inadvertently. I wrote it before the 2007 papers, but I had sort of, I guess, guessed well, and this is a white book we wrote on hormonal therapy. And in it, I basically talk about approaching metastatic prostate cancer like a play with two acts. Act one is getting a complete remission. Act two is maintaining that remission off toxic treatment. Now this fits very well into this current plan. So when I see someone with metastatic disease, I first ask, what do I need to do to get this person into complete remission? Then once complete remission is attained, I ask, what can we do to keep the cancer from coming back that's compatible with this person's health and likely to work with the cancer they've got? Complete remission means the PSA less than 0.01, and it means the absence of any detectable metastatic disease. So if you have bone metastasis, this means the bone lesions must heal and return to normal. So in the White Book, what we talk about is a way of orchestrating treatment. And I'm very much into this. I think many doctors and patients are looking for the silver bullet, but no one agent's going to cure this disease. What we need are team players, drugs that pull together. I call this the Obama approach to medicine. The drugs have to pull together to get you there. The mathematics of this is interesting. Just think of this. If there's a 1 in 10 chance of the cancer being resistant to each of 3 agents. So if you use each agent in turn, there's a 1 in 10 chance of resistance being present. So you're quickly going to run through your agents. If you get the 3 together, they multiply, so it's 1 in 10, 1 over 10 times 1 over 10 times 1 over 10, or 1 in 1,000. Or if it's 1 in a million, it would be 1 in a million times 1 in a million times 1 in a million, or 1 over 10 to the 9th, a billion. So quickly combining drugs makes the development of resistance far more difficult. This is why when you treat tuberculosis, you don't use 1 drug, you use 3 or 4. This is why when you treat AIDS, you use 3 or 4 drugs to treat AIDS. This is why all the cancers that we cure with drugs are cured with combinations, not single agents. Not an accident. So you have to combine things. So what I do is I'll start the patient on standard hormonal therapy with Leucron and Casodex and Proscar Avodart, the typical triple hormonal blockade, and I'll follow the cancer carefully. And if the patient goes into complete remission on hormonal therapy, hey, that's great. But more typically what you'll see is the PSA will fall to a certain point and stop. The minute it stops, I would like to move to the next phase, second-line hormonal therapy. I don't want to let the cancer materially progress. Now, the way the world works, of course, patients may be 6,000 miles away, and the PSA may not have been gotten for 5 months. So there's a slip between the idea and the action that can sometimes happen. But we try and move on to second-line hormonal therapy as quickly as it becomes apparent that the first-line hormonal therapy isn't going to get us in complete remission. Now, we've developed, I think, a very effective second-line hormonal therapy program that starts with Eric Small's observation that leucine and ketoconazole are so synergistic, giving a 75% response rate. And to that, I've added transdermal estrogen. Estrogen, the female sex hormone, given through a skin patch. And this seems to be extraordinarily effective treatment. And a lot of patients will go into complete remission on that alone. And it's pretty fast. Usually within 4 months, you'll see most of what you can get, although some patients, it will drag out longer. What if this doesn't get us to complete remission? Then the next phase is to go to Taxotere. But you're going to Taxotere when the cancer's already at low ebb. Now this is a very different experience using Taxotere when the PSA is 0.5 and you're trying to get it to 0.01 than when the PSA is 2,000. It's much harder road for the Taxotere if it's starting with a large mass of cancer than a small mass of cancer. So I'm not a great fan of letting the cancer grow big enough to be worth using Taxotere. Taxotere is an agent that in clinical trials prolongs life. So it shouldn't be thought of as a palliative agent. It should be thought of as an agent that prolongs life. And in that setting, the lower the cancer volume when you start treatment, the better it will be. So Myers' rule number 1, more cancer is not better. And you don't want to wait for more cancer to develop to jump in with treatment. So we'll typically send someone from Taxotere with a PSA levels that are really, really low and cancer volume that has been reduced to the minimum level possible. Now, this is a controversial stance. Many other medical oncologists would disagree strongly with me. To give you a sense of this, I had a patient whose when his PSA was 34, he developed a metastasis to his spine that was pressing on his spinal cord and causing early paralysis. We irradiated that lesion and relieved the paralysis. But it was clear to me at that point hormonal therapy had failed. So it was time for chemotherapy. I referred him to the Cleveland Clinic. And they said, oh, well, we just, as a policy, don't treat with Taxotere till the PSA hits 100. Well, I kind of disagree with that because there are patients walking around with widespread metastatic disease and a PSA under 10. And they're the people that have more aggressive disease and need chemotherapy early. So I think that doesn't make much sense, and I said so. It doesn't endear me to some of my colleagues. So in the book, I give patient examples, and there's a baker from Pittsburgh, patient XD, and he started with a PSA of a little bit more than 1,000 and bone and lymph node metastasis. And we used Leuperon and Casodex. And we used the estrogen, ketoconazole, and leucine. And when we sent him for Taxotere, his PSA was under 1. But it took us a long time to get his PSA from 1 to less than 0.01. It took 2 different chemotherapy combinations, and then finally we had to return to leucine. And it was chronic leucine over many months that finally got him into complete remission. He then had 3 years off of toxic treatment on Avodart and leucine to maintain him. He couldn't take Celebrex because his heart health was not good. Finally, this last 2 months, his PSA had gotten up to the point where he had detectable recurrent lymph node metastasis, and we had to put him back on hormonal therapy. So our ability to keep him from relapsing, this approach of tumor latency, was less than perfect in his case, and only brought him 3 years off of treatment. But still, I think that most of you would recognize that this is an unusually favorable outcome for someone who presented with a PSA of 1,000 and bone metastasis to have 3 years off toxic treatment. I wonder if his heart health had been sufficient that I could have used Celebrex or Sutent whether the outcome might have been better. But he'd had at least one massive heart attack, stents, and had intermittent angina, and was on nitroglycerin at least once a day. So I thought that Celebrex and Sutent, based on what we know, are not possible. So this comes to the final point, and that is what we can do today depends on other diseases than prostate cancer that might affect the agents that we can use. One of the questions that I got before I got up here is, what is the role of diet on prostate cancer, diet and nutrition? Then we had a trial from from Finland, with 26,000 men who were 3-pack-a-day cigarette smokers. And the idea was to try and prevent lung cancer. So they had one group that had nothing. One group got vitamin E, 50 international units. A very safe dose. Actually, one you might obtain in a diet if you eat a lot of almonds. Beta-carotene alone and the combination. After the people had been on the trial between 5 and 8 years, it took 3 years to get all these people on, they noticed there was a reduction in death rate among the people on vitamin E. A 40% reduction in overall death rate. And thinking that this must be lung cancer, they looked, and no, it wasn't lung cancer, it was prostate cancer. The death rate had dropped much more than the incidence. The incidence had dropped about 30%, but death rates by 40% within 5 to 8 years. And the beta-carotene arm, the death rate increased by 30%. And when vitamin E and beta-carotene were combined, they canceled each other out. And I remember the editorial that was written at this, and they said, to reduce the death rate that much, vitamin E can't be preventing prostate cancer. It's got to be preventing progression of aggressive disease, because you don't go from not having prostate cancer at all to dying of it in 5 to 8 years. It's true. They then went on to stop the vitamin E, and within a few years, the group on vitamin E fell back to the control group. So the benefit of vitamin E was reversible. Now, this led to a great interest in the pharmaceutical industry, and so the pharmaceutical industry went and developed a whole series of vitamin E analogs that were patentable, so you'd have to get a prescription to take them. And these have been put into clinical trial. I don't know what's happened to them, but at least that was the direction that was taken. And gamma tocopherol was more active than alpha tocopherol by a huge margin in this process of finding out what was more active. Then there's the selenium trial, which was conducted in the mid-Atlantic region of the United States, because that's an area of the United States where selenium deficiency is endemic. Enough so that many of the local hospitals have the facility to measure serum selenium levels for the kids and for people on artificial feeding. So it was placebo versus 200 micrograms of selenium. And at the end of 10 years, there was a reduction in overall death rate in the people on selenium that was statistically significant. So this is a selenium-deficient population, and they're given supplementation. And there's a reduction in overall death rate, and it's a randomized controlled trial. When they went in to look at what caused the reduction in overall death rate, there was a 64% reduction in prostate cancer deaths. There was about a 40% reduction in colon cancer, and about a 30% reduction in lung cancer rates. Those are the big cancers that were affected. There are also some minor, less common cancers that were affected. Head and neck cancer, huge impact on head and neck cancer, for example, and certain of the leukemias and lymphomas. So that was with the selenium yeast. And so this is what led to the clinical trial that now is a bust. But some people would look at this new clinical trial and then throw this whole story out the door. Well, I'm more of a basic scientist than I'm a clinician, to tell you the truth. And I first look for a sound basic science story. And then if the clinical trial doesn't support the basic science, I ask, well, is it because the basic science idea is wrong? Or is it because the clinical trial had a design flaw? And so at this point, I think it makes a lot of sense to continue antioxidants for the reasons I've said. Not because it's going to stop your PSA rise, but because it will prevent genetic damage to your cancer that fuels the change of your cancer to something more aggressive and nasty as time passes. That, I think, is the most serious problem we face with metastatic disease, is the propensity of the cancer to become more nasty as time passes, which is an evolutionary process. So evolution is alive and well in the oncologist's practice, and we would like to stop it. The other nutritional item, the two other nutritional items that are very important that don't fit in this general outline. One is vitamin D. Harvard School of Public Health is following physicians and male nurses aging, and 77% are deficient in the winter and 55% are deficient in the summer. Vitamin D deficiency is extremely common in America in men in their 50s, 60s, and 70s. You think, oh, well, I'm in the sun, I don't have to worry about it. But by the time your skin is wrinkled or your hair is turning gray, your ability to make vitamin D is also failing. So when these papers started coming out, I started measuring vitamin D levels in my patients, and I am stunned at how deficient people are. It's the rule that people's vitamin D levels will be low when I see them for the first time. It's also, the recommended daily allowance of 400 international units is silly to the point of absurdity. It only continues to be a recommendation because people want to cover their ass. They don't want to admit how wrong they are. But clearly, the medical literature indicates it takes roughly 5,000 units a day to maintain blood levels where they would have been if you were a 20-year-old Caucasian male spending time in the sun. Or if you were wearing a loincloth and living in Africa, your vitamin D levels would be 70 to 100 nanograms per mil. Well, for most of us, that's going to take a minimum of 5,000 units to get it there. So there's a study from Toronto, a group of patients who failed surgery or radiation, who had modest doubling times on the order of a PSA doubling every year. And in half the patients, the cancer was arrested by reversing vitamin D deficiency. That's pretty stunning. Just reversing vitamin D deficiency, that's all. And there are many other health benefits to that. So I think it's a no-brainer to have your serum vitamin D level measured and to take a dose sufficient to bring you up into the healthy range. What's the percentage of being deficient enough you're going to lose bone and develop osteoporosis? Very interesting study in postmenopausal women. Placebo versus just over 1,000 units a day. Not even enough, right? A 5-year study. So during the first year on vitamin D, there was some reduction in the risk of cancer, but not much. But thereafter, there was an 80% reduction in the risk of these women developing cancer with just 1,000 international units a day. Big impact on breast and colon cancer incidence, but other cancers are infected as well. So I think as a basic public health measure, every family practitioner should be measuring vitamin D levels and advocating the use of vitamin D. Now, there are two forms of vitamin D. Vitamin D3 is the natural human vitamin. Also, all other mammals use this. Actually, it's the biologically normal form of vitamin D. Commercially, there is another vitamin D called vitamin D2 that's made by taking yeast and exposing them to ultraviolet light. And as a breakdown product of the cell walls of the yeast, has some vitamin D-like activity. That's dirt cheap for them to make. So over the counter, some of the cheap forms of vitamin D are vitamin D2. There's also a 50,000 unit pill available for prescription that's vitamin D2. The vitamin D researchers that have reviewed this subject uniformly feel that vitamin D2 is not an adequate replacement and should not be used. Vitamin D3 is available dead pure, dirt cheap. The best brand I have found is Life Extension. And it's $10 for 60 pills of 5,000 units. So you can't get cheaper than that. I mean, there's just no sense in playing around with junk. The final thing I'd like to talk about, and then I'll open for question and answer, is pomegranate. And when this paper first came out in April of 2005, my first reaction was to ridicule it. Boy, did I have to eat my hat. I got a hold of the paper, and it is a superb clinical trial. In fact, I regard it as a model for how to test a dietary item in the treatment of prostate cancer. Beautiful work done at UCLA. David Heber's involved. Ingaro, who got the Nobel Prize in 1998, was a co-author. So just an outstanding piece of clinical investigation. And they took a group of people who had failed surgery or radiation. The PSA doubling time was on average 13.5 months. So relatively slow-growing prostate cancer. They put them on 8 ounces of pomegranate juice a day from Palm Wonderful. And the median PSA doubling time went from 13.5 months to more than 50 months. Now, if you want to have an interesting exercise, take a PSA of 0.1 and double it every 55 months. Now, it takes a PSA of at least 500 for people to be in trouble with metastatic, for most people to be in trouble with metastatic disease. And I think you realize that with a 50-month doubling time, you're going to get into trouble at age 120 maybe. So, the tragedies of prostate cancer. Now, it's even more impressive because 20% of the patients, the PSA fell, and they threw them away because you can't measure a doubling time when the PSA is falling. So this is one of these papers that's so conservative about the interpretation of the data that the story is far more dramatic than the dramatic results they reported. And again, I have been stunned at what I've seen in the clinic with pomegranate. I have seen, now there's an element of luck to this as with everything, but I remember one case, this guy is another one of these Gleason 10 14-day doubling times. Why does that stick out in my mind? Because that's as bad as it gets. That's the most aggressive form of prostate cancer, 14-day doubling time Gleason 10. And this guy had failed everything, chemotherapy included, and his PSA was 1,000. It was December of 2006. Well, a 14-day doubling time and a PSA of 1,000, it means PSA is going to be 4,000 a month later, right? And with his disease, that wasn't compatible with survival. And he was a support group leader from his local town, so he knew that he had less than a month to live. And we were sitting there talking, about, well, what hadn't he tried? And I said, well, why don't you try this pomegranate stuff? There are extract capsules, so he was going to take 4 capsules a day. Stopped his disease dead in its tracks. He went from intravenous morphine to oral morphine as the months passed for bone pain. then Celebrex, and finally Tylenol. Finally, after 7 months, the cancer got resistant to this and exploded again. But still, he had a longer response to pomegranate than he had to Taxotere, for Christ's sake. So I think that's pretty dramatic. Again, pomegranate has many other health benefits. University of California, San Francisco, people with angina and coronary artery blockade, a dramatic improvement in cardiac blood flow within 90 days. It drops the systolic blood pressure in people with hypertension, lessens the risk of carotid artery thickening. So again, absolute no-brainer. The only issue is, of course, pomegranate juice has a lot of sugar. So if you're a diabetic, you're better to take the capsules than the juice. If you're not a diabetic, you can enjoy the juice if you want, or take the capsule. All right, that's all. I was going to get into oligometastatic disease, but I really covered that well at the PCRI conference, and I gather you folks have access to the DVDs of that conference, so I'm open for questions. How do you want to do this?
Well, let's have anyone with questions come on up. We'll form a line over here. We'll use the mic so everybody can hear the question. And we'll go with Harry. First question.
Thank you, Dr. Myers, for an outstanding presentation. I think it's the fact that the breast cancer research is way ahead of prostate cancer research. And for our wives and daughters, how would you anticipate your regimen for prostate cancer? How effective would you think it would be for breast cancer, which are supposed to be somewhat similar diseases? And what is actually used in breast cancer by comparison?
Well, it's interesting. More money is spent, and more literature is accumulating on breast cancer. I think the progress is slower, because I think breast cancer is inherently a more difficult disease to treat than prostate cancer. Aggressive prostate cancer is less common than aggressive breast cancer. Also, because we can measure the PSA doubling time, we can spot agents that slow the growth of prostate cancer easier than they can spot something that slows the growth of breast cancer. It's really hard to show that something has dropped the growth rate of a woman's breast cancer in half. So most of the breast cancer stuff is in the laboratory, not in the clinic. The pomegranate's a classic example. Most of the laboratory work on pomegranate and cancer is in breast cancer. The prostate cancer came late, and there are only a few papers in the laboratory. So there's a strong rationale for using pomegranate for slowing the recurrence of breast cancer, just no human clinical trials. The same thing with resveratrol, the active ingredient in red wine. There are now 140 papers on the ability of resveratrol to retard the progression of breast cancer in the laboratory in many different settings without, I think, any negative observation yet. And it also seems to lack side effects, except the ones I talked about. Vitamin E in the laboratory appears to play some role in preventing the dormant breast cancer cells from activating. But again, only laboratory work. And finally, the leukine story. There are 2 clinical trials that suggest that leukine is triggering enough of an immune response to retard the progression of breast cancer. But it's less far along than the prostate trials.
Okay, thank you.
Again, outstanding. We enjoy your presentations. 2 questions. Earlier in the evening when we were speaking, you talked about 2007. Before and after, we've come to recognize historically that there was a period in prostate cancer effective treatment before 2007, and then what's coming after. And the other half of my question for the audience is, when you draw a new conclusion from your research and perhaps publish a paper, how can we all find it somewhere? Perhaps on the internet?
Well, you know, our nonprofit foundation, actually, despite the economy, has been able to raise enough money that I've hired a person to come in and review charts and get papers ready and to design clinical trials. So hopefully that will be happening over the next year. Well, it depends. I think that if you're going to submit for publication to a journal, you can't pre-release it. So if I decide to publish in a medical journal, I've got to play their game. The real issue is whether we're going to let the data out without putting it in the paper, just put it up on the net for everybody to read. So this is one of the things that we're struggling with.
And the 2007 question, you see a difference before and after how?
Well, I think I've mentioned the whole idea of stem cell disease and the preservation of complete maintaining tumor dormancy. Yeah. I would say the other study I would add is a clinical trial called SWOG 8794. This completely changed my own thinking. These are people with high-risk, newly diagnosed disease, Gleason 8 through 10, elevated PSAs, or evidence that the cancer had broken through the capsule. So these people all have a high risk of recurrence after surgery. So the clinical trial involved doing surgery on all of these patients, and in half the patients, they had radiation therapy to the pelvic lymph nodes at half the dose that you would use to treat prostate cancer in the prostate. Now that sounds like a trial that's destined to fail for two reasons. One, the dose of radiation was too low. And second, gee, we knew that this disease was spread everywhere, right? Turns out not to be the case. 5 years later, the people who had surgery and radiation, 77% were free of disease. Those that had surgery alone, it was down in the low 30s. So what this said is that in patients, these high-risk patients, although they were destined to get distant metastasis, at that point in time, the cancer cells that were causing the metastasis were out of the prostate but still in the pelvis. And furthermore, they were exquisitely sensitive to radiation. So what this means is that in high-risk patients, the cancer isn't either in the gland or everywhere. In fact, for most of these patients, it's still in the pelvis. And this follows a whole series of other papers to suggest that prostate cancer, rather than going from prostate to everywhere, actually proceeds through a very gradual step of first the pelvic nodes and then distant metastatic disease to a few sites, and then those few sites seed other sites. And that if you intervene aggressively to kill those early metastases, you can cut off this evolution. So that was another example of something that completely changes my view of the disease.
Dr. Myers, thank you very much for a wonderful presentation. I saw you in your office about 3 years ago, and we talked about Combidex.
Mm-hmm.
I just came back from Holland. They found a 5-millimeter spot in my lymph nodes. Now I got to decide whether to zap it with more radiation or not. But could you comment on an update of Combidex?
Oh, yeah. Well, this was a big topic at the PCRI conference. Dr. Scholes, Dr. Strum, and myself have all independently seen this as a transforming event because we now can spot these the whole concept of limited metastatic disease. Combidex tells us where the disease is. And you irradiate the positive spots and people are going into remission. People have recurred after surgery and radiation, that's one thing, but I'm having people come into my office who have failed hormonal therapy and are about to start chemotherapy. And when we study them, we find they have just a few metastatic sites. And if you irradiate those metastatic sites there, instead of going on chemotherapy, they have an undetectable PSA and they're not on any treatment at all. So I think this is really exciting. There are many people walking around thinking they have metastatic disease that is incurable when that's not the case. And the Combidex is the best tool we have today to find out where that disease is. It's not perfect, but it's the best tool we got.
Just the last tag on that question, when will it be available in the United States?
I have no idea. I have never been good at guessing when things will get FDA approval. I will say right now, there is no company even interested in bringing it to the United States.
My question goes back a little bit. You mentioned selenium yeast. I take normal pills from my vitamin store. How would I recognize whether it's yeast or not?
Well, that's if you go to most health food stores and buy a selenium capsule, it will be selenium yeast.
Okay.
Because it's dirt cheap to make.
Very good. Coumadin, you mentioned it interacts with the ingredients in red wine. Does it interact with red wine proper?
No, because there's not enough resveratrol in the red wine.
Okay. And you mentioned also some drugs shouldn't be taken if your blood pressure is high. Now, if your blood pressure is uncontrolled through drugs, does that give you a pass, or are you still a high blood pressure candidate?
I'm not sure I understand the question.
My blood pressure is low thanks to drugs I take to maintain it. Would I still be considered a person that should avoid blood pressure reacting drugs like Celebrex, for example?
Well, you still have hypertension, but it's treated.
Yes.
So if you were to go on Celebrex, you would need to have a blood pressure cuff and check your blood pressure in the morning, say 3 times a week, to make sure that your blood pressure doesn't start to go up when you're on Celebrex. You should also make sure your LDL cholesterol is under 100.
Okay. Got it.
Thank you, Dr. Myers.
Hi.
How are you doing?
Good.
There seems to be a small population that has an allergic response to leucine, and I'm wondering if you know if there's any work going on similar type drugs that might avoid that.
The only real, yes, this is first, it's a foreign protein, so you can be allergic to the protein. And second, it's stimulating the immune system, and that can include allergies. So patients really should take an antihistamine with it. The only answer to that is to develop a vaccine that's specific for a target and not take a non-specific approach like leucine.
The estradiol patches,
Mm-hmm.
I don't know if you've seen the most recent edition of Life Extension Foundation. They've got a long article in there that suggests difficulties with estradiol, and I just wondered what your response to that is, if you've seen the article.
Well, yeah. Well, of course there are difficulties with estrogen, but there are with Lupron too, and chemotherapy and radiation therapy. Does anyone know of a systemic treatment for prostate cancer that doesn't have a problem? I mean, I don't know. I was on Lupron and Casodex for 18 months, and it sure worked against my cancer, but it almost worked against me as well. And estradiol has problems, obviously, as all hormonal therapies do. Yeah. Yeah.
Hi, doctor. I just wanted a clarification on this. The blood flow that increases tumor growth, would heavy exercising, aerobic exercising with weights, generate the kind of blood flow that might cause the tumors to grow?
No, because you have the cart before the horse. Blood flow doesn't cause the cancer. The cancer causes the blood flow. So the cancer produces a hormone that attracts blood vessels to it and enhances its blood flow. It isn't that the blood flow is rapid and then that causes the cancer to grow. The cancer is the initiator of the whole process.
Great. One other quick one, if I might. Would pomegranate juice interfere with any other medications that you know of, like, let's say, a statin drug or something?
Well, there's some published claims about that. And my yardstick for a drug with a problem in that direction would be ketoconazole or grapefruit juice. I've not seen any interaction between pomegranate and statins or any other prescription drug, including blood thinners, despite the published claims that they do exist. Yeah.
Thank you very much.
Mm-hmm.
Excuse me.
Thank you. It was extremely interesting. In fact, you've answered a couple of my questions while I was standing here. But resveratrol, is that a blood thinner by itself or only in that combination that you described?
It's only a blood thinner in combination. It itself doesn't have any effect on coagulation.
Even with aspirin or any other blood thinning?
Well, it interacts with things like Coumadin and Plavix. It decreases the effectiveness of Plavix and increases the effectiveness of Coumadin. So you need more Plavix and less Coumadin.
Right, but I
so
was
it's
thinking...
possible to give resveratrol to patients on these drugs, but it needs a physician who really understands the details of how drugs interact.
Yeah, I was thinking more of aspirin or fish oil or some other things that have mild blood.
Fish oil is not a blood thinner. Fish oil does not affect blood clotting. That's one of the myths out there in the medical field. And when clotters, experts in clotting, have looked at this, they can't find any impact of fish oil on clotting. Aspirin, there's no interaction with aspirin.
Okay. And safe dose of gamma E, you said non-bleeding dose less than 400 units?
As a general rule, I think it's important to stay less. We try and keep everyone below 200 international units a day.
Okay. Thank you very much.
Doctor, before we have our next question, for those who don't know how to get your click on your website, can you give that address for everybody that might be interested in writing it down?
Prostateforum.com. And I think my wife has some free newsletters in the back. Yeah. Okay, yeah. So a bunch of paper handouts, newsletter samples, and some other educational material. But prostateforum.com is our website.
On the subject again of selenium, my health food store doesn't have anything that says selenium yeast. Is it another chemical name? Generally, it starts with the chemical that you mentioned with M. Is that
selenomethionine?
Yeah. Is that selenium yeast?
No, selenomethionine is methionine is an amino acid that the body uses, and selenomethionine is one where the sulfur is replaced by selenium. But it doesn't have the same biological effects that the selenium yeast would have. I am surprised that your health food store wouldn't have the yeast. On the East Coast, it's everywhere.
I looked at 3 or 4 brands. I'll look again.
Yeah.
And
the ultimate amino acid in glutathione peroxidase is selenocysteine, and Life Extension does sell a selenocysteine preparation.
And is that yeast?
No, it's just straight. It's
stuff.
a mixture of purified amino acids.
Okay.
But it would affect the ability to. It would positively benefit the destruction of hydrogen peroxide.
Thank you.
Dr. Myers, thank you for your fine presentation and for taking our questions. And I wanted to know, I've been to a couple of the PCRI conferences, and I've heard a couple of presentations where doctors made connections between high sugar diets and high animal protein diets and potential prostate cancer. So I'd like to hear what you have to say about that. And also, I'm wondering if things like saw palmetto or raw almonds or or some of those other health aids have any effect on prostate cancer?
Yeah, well, the nutrition story is infinite in an extent that you could go on with a 3-hour presentation and all these details. There's a very strong case to be made of the link between red meat consumption and the development and progression of prostate cancer. The high omega-6 fat content of red meat is one story. The other is when red meat is cooked at high temperature, a chemical forms called PHIP, which is very tightly linked to the development of prostate cancer. You know, those of us who grew up after World War II, we're the Weber grill generation. You could say this is the Weber grill disease. So I think there's no question about that. On the other hand, there is abundant evidence that fish consumption reduces the risk of metastatic prostate cancer. So there's absolutely no evidence that you need to limit or reduce the fish content of your diet. And in particular, there's no evidence that a vegan or vegetarian diet is better than a diet that incorporates fish. Sugar and prostate cancer. Well, there's what I call the Harry Potter School of Science. And that is that if you wish something to be true and you say it often enough, it will become true. So the statement that sugar feeds prostate cancer is in that order. It's the Harry Potter School of Science. There isn't a single shred of evidence to support that statement. In fact, the evidence we have is that sugar suppresses prostate cancer. First study was Harvard School of Public Health. This is the same group that we've talked about all night long. And they started by looking at the consumption of fruit and fruit juice. And sure enough, the more fruit or fruit juice you ate, the lower the risk of metastatic prostate cancer. They said, well, you know, fruit has the good things and it has all the sugar. How can we tease out the relative contributions? Oh, well, let's look at Coke and Pepsi, 7-Up, and sugar candy. Well, the more Coke and Pepsi and sugar candy you ate, the lower the risk of metastatic breast cancer. 40,000 men followed for 10 years. This is not, and Harvard School of Public Health, this is not a lightweight group. So that paper got published, and you know, the folks that say that sugar feeds prostate cancer conveniently just ignore the existence of these papers. So then comes the next study. Well, gee, if that's true, what about diabetics? You know, bad disease. Well, diabetes reduces the death rate from prostate cancer by 50%. These guys never talk about that paper, you know. I mean, then, PET scans. Well, you will do PET scans because PET scans require the uptake of glucose, and we use PET to visualize cancer. Therefore, that proves that prostate cancer takes up sugar, except that most prostate cancers are invisible on PET scan. And PET scans aren't recommended as a visualizing tool in prostate cancer unless you're dealing with aggressive, rapidly growing disease. Well, that suggests that prostate cancer doesn't even pick up sugar, let alone grow from it. Well, it doesn't pick up sugar. What does prostate cancer use for energy? Turns out it uses palmitic acid, an 16-carbon saturated fat called palmitic acid because it's first described in palm oil. Rapidly increases prostate cancer growth in the test tube. If your diet doesn't contain enough palmitic acid for the cancer to grow, it can mutate to make its own. There's an enzyme called fatty acid synthase that makes palmitic acid, and the folks at Johns Hopkins have shown that this is what happens in high-grade disease. One of the major genetic changes in high-grade disease is the ability to make their own palmitic acid. Well, what's unique about prostate cancer? Well, prostate cancer has a lot of mitochondria. It's one of the few cancers that uses aerobic metabolism. It doesn't use anaerobic metabolism, and it burns fat. So this whole Warburg study, it doesn't absolutely pay any relevance to prostate cancer. And folks who say sugar-free prostate cancer, I would challenge them to find a single paper in the medical literature to support that statement. That isn't to say that other cancers might be affected, but for prostate cancer, gee, where's the beef? Next comment.
Hi, retina specialist recommends a vitamin with a very high vitamin A beta carotene for macular degeneration. Would this be bad in the case of metastatic prostate cancer?
Well, there are reasons to be concerned about beta carotene and prostate cancer. I mentioned the Finnish study where the group on beta carotene had a 30% increase in death rate. And then a year or so ago, the National Cancer Institute reported a study on multivitamins, and the more multivitamins a man consumed, the more likely they were to develop aggressive prostate cancer. And of course, multivitamins have usually 5,000 units of beta carotene. And then finally, there was a study from the Fred Hutchinson Cancer Center, and they found the higher the serum level of beta carotene, the greater the risk of aggressive prostate cancer. So I think that beta carotene isn't necessary for macular degeneration. You can get by with other carotenoids, zeaxanthine, lutein, and so I would stay away from beta carotene if you have nasty prostate cancer.
I have a question. By taking vitamin D in the appropriate amount, the calcium level goes up over the limits. And when the vitamin D is lowered, then the calcium level comes back within limits.
That shouldn't be true.
It shouldn't be true?
No, it's certainly in my experience and in the published literature that isn't true, unless you're taking astronomical amounts of calcium by mouth.
Okay.
There have been clinical trials of 10,000 units a day indefinitely with no hypercalcemia. There's a clinical trial for multiple sclerosis where they're giving industrial strength vitamin D levels to treat multiple sclerosis without hypercalcemia. Hypercalcemia is never caused by vitamin D3 unless the person is taking excess oral calcium.
There's a book, the China study out there. Could you tell us something about the relevance to that, to us here, that study?
I can't understand.
The China study.
Yeah.
There's a book out there, the China study. Could you tell us the relevance to us of that study?
So the China study isn't a study. The China study is a population observation.
Oh, I see.
No one has taken a group of patients and randomized them to a high and a low protein diet. So it's phenomenology. You follow what I'm saying?
I hear what you're saying.
Yeah. There's no interventional trial
I see.
to show that reducing protein content of the diet lowers the risk of prostate cancer or slows its progression. It's a rational hypothesis based on sound population data, but no one has formally studied it. So it's one of those things that are hanging out there. No one's even done a phase 2 trial. No one's taken a group of patients with prostate cancer and a measurable PSA doubling time and see if they could slow it by reducing protein content in the diet. Now, having said that, I think the diet they're advocating is reasonable. But as I say, it's very clear that eating fish in large amounts, which is high in protein, high quality protein, animal protein, does not increase the risk of metastatic prostate cancer. In fact, up to 5 servings a week, you reduce the risk of metastatic disease. So there's a lot more than meets the eye. So I think that while the sugar thing doesn't deserve any respect, the China study proposes an interesting hypothesis that should be tested in a randomized controlled trial.
Do you know of Guoling Qigong, a Chinese exercise that has effect on cancer?
I'm sorry?
Guoling Qigong, it's called, a Chinese Qigong that has an effect on on cancer, and it's been studied. Do you know anything about those studies? Thank you.
Six years ago, my PSA was 2. The doctor didn't think I had a problem, but because my father and my grandfather had both had prostate cancer, he decided to do a biopsy. The biopsy was positive. I had external beam radiation. My PSA went down to 0.014. It stayed there for 5 years, then it started coming up again. I've had 2 biopsies, and they are both negative. So the assumption is that it has left the prostate. And you said that when it does that, it's probably localized in the pelvis area and is relatively easy to kill. How can you find it, and how can you kill it?
So a lot depends on the details of your radiation therapy. Did they irradiate just the prostate, or did they do the pelvic lymph nodes? But if they only irradiated...
I had 38 treatments.
That doesn't answer the question for me. If they've just irradiated the prostate, then the odds are decent that it's still limited to the pelvis. There's no way to be sure of that without trying to image it. In the United States, the best technique is the prostate scan, which has about a 20% false positive and 20% false negatives. So it's not perfect, but if the prostate scan shows no disease outside, no, I'm sorry, that's for post-surgery. The prostate scan can image lymph nodes in the pelvis, but there's about a 20% false negative rate. This is actually how I visualized my pelvic lymph node disease back in '99. So in the U.S., you could have a prostate scan, and if it picked up an area of positivity, they could irradiate